So infectious disease course day 4, time is 8 to 4. The theme of the day is fever and fever of unknown origin, that is known as FUO. So for the first 3 days we have read what is infection versus colonization, diagnostic specimens and antimicrobial selection. And today we study the most common and challenging symptom in infectious disease, that is fever. So what antibiotic should we start? Why does this patient have fever? So physician asks, what antibiotic should I start? An ID physician, which is infectious disease physician, he asks, why does this patient have this fever? So in the pre-round, the case 1 is 45-year-old male, fever is for 3 weeks. Investigations done were blood culture negative, urine culture negative, chest x-ray normal, empirical antibiotics were given for 10 days and no improvement. So patient may ask, is this sepsis? Think carefully. Fever is not equal to infection. So differential diagnosis broadly divide fever into infectious cases, causes and non-infectious causes. In infectious causes, it may be tuberculosis, endocarditis, abscess, viral infection, any fungal infection. Whereas in non-infectious causes, it may be autoimmune disease, malignancy, drug fever, thromboembolism. So teaching pearl is that never anchor on infection. The longer fever persists without evidence, the broader your differential should become. So next hour, you go for approach to fever. Every fever patient should be approached systematically. So duration is acute, subacute or chronic, that is less than 7 days, 1 to 3 weeks or more than 3 weeks is chronic. If there any travel history is there, animal exposure is there, occupational exposure is there, immunocompromise, recent surgery, drug exposure. So senior question, why is history so important in ID? Because diagnosis often comes from history before investigations. So fever of unknown origin, that is FUO. Its classic definition is fever is more than 38.3 centigrade. Duration is more than 3 weeks. No diagnosis despite appropriate evaluation. So the common categories: infection, example is tuberculosis, deep abscesses, infective endocarditis. Malignancy, examples lymphoma, leukemia. Autoimmune, examples systemic lupus erythematosus and vasculitis. Miscellaneous, examples drug fever and thyroid disease. So the important rule is, do not start empirical antibiotics in every FUO. Antibiotics may mask diagnosis, reduce culture yield, delay definitive diagnosis. So coming to the bedside teaching, here we have case 60-year-old diabetic, intermittent fever for 1 month. Finding is weight loss, night sweat, ESR elevated, CRP elevated. So the question is, what diagnosis immediately comes to your mind? Possible consideration is tuberculosis. Lymphoma or endocarditis may also be there. So teaching point is, constitutional symptoms are weight loss, fever and night sweat should trigger a broad differential. And endocarditis pearls here are, always consider infective endocarditis in prolonged fever, if there is heart murmur, if there is prosthetic valve, if there is recurrent bacteremia. So diagnostic workup in these cases is, multiple blood culture should be done, echocardiography should be done and careful examination. So during the lunch time, drug fever should be read carefully, and which is most of the time frequently missed. So what is drug fever? Coming to the case 3, Where patient is clinically improving, cultures are negative, but fever persists. So current medication, multiple antibiotic and anticonvulsants are being given. So senior may ask question that could medication be causing fever? Yes. Drug fever is often overlooked. Clues: patient appears relatively well, no clear infectious sources, fever persists despite broad antibiotics. So here the teaching pearl is that one of the causes of persistent fever is the antibiotic itself. So fever in a special host like neutropenic fever, medical emergency, it is a possible sign of infection may be minimal. So sign of infection here are minimal. So your senior may ask, can a neutropenic patient be septic without obvious finding? So answer is absolutely, because inflammatory responses are blunted. So important principle here is that treat neutropenic fever promptly. Transplant patients consider opportunistic infection, viral reactivation, and fungal disease. In the next hour, diagnostic reasoning should be done. For example, if the case is of 28-year-old women, fever is for 4 weeks. Now, investigations done are blood culture is negative, urine culture is negative, CT chest is normal, additional histories of joint pains and facial rashes. So, should we keep escalating antibiotics? No. What else should we consider? Autoimmune disease, because joint pain is there and rashes are there. So, teaching point here is that not all elevated CRP values indicate infection, always correlate clinically. So end of the day, fever checklist should be seen. When evaluating fever, always ask what is the clinical syndrome, where is the infection source is important, host is any immunosuppression history is there, devices, any catheter or prosthesis is there, any travel history is there, any drug history is there, because it can be a drug fever. Non-infectious causes like autoimmune or malignancy may be there. Now the rapid fire questions may be that most common mistake in prolonged fever is that assuming every fever is an infection. No. So most important diagnostic tool in fever of unknown origin, it is detailed history and repeated clinical examination. Then should broad spectrum antibiotic be routinely used in FUO? No. So three major categories are either it is infection, or it may be malignancy, or it may be autoimmune disease. So what thing you should do is that read about tuberculosis is a cause of FUO, then infective endocarditis, drug fever, these all you should know in detail. Neutropenic fever, approach to prolonged fever. Then a junior doctor sees fever and thinks which antibiotic should I start. Whereas if senior sees, he says what biological process is generating the fever, whether the antibiotic should be given or it shouldn't be given. So these all things should be read. Then if you want to read more, then post round follow up should be done. That new culture report, if have been added, it should be checked. Any ST result, any blood culture alerts, imaging reports, changes in patient condition is there, then you should ask, has my diagnosis changed? What I was thinking, is that changed now? Do cultures support my treatment? Is it the same thing what I was thinking? So can antibiotic be narrowed now? Is source control or adequate? That should be done in the evening. So then FUO approach, that how to approach FUO, it is also an important topic and one should read about it. Infective endocarditis is cause of fever most of the time, so it should be read because so many times infection sepsis takes place. Then the drug fever is also very important, it should be read. So these things should be cleared in mind, and one guideline section, one review article, these all things should be added, one landmark paper summary, and the excellent sources for ID person is Infectious Disease Society of America guidelines, European Society of Clinical Microbiology and Infectious Disease guidance, WHO infectious disease resources. These are important resources which one should read. Then microbiology correlation is important. As a microbiologist, this is where you have a major advantage, that one can read these important organisms like Staph aureus, Klebsiella pneumoniae, Pseudomonas aeruginosa, and Enterococcus faecalis, and read about their virulence, their resistance mechanism, what clinical syndrome they may cause, treatment options available, and then one should have that antibiotic notebook also. In that you can read for each antibiotic what is the spectrum, what is their PKPD, what is dose, renal adjustment, tissue penetration, major toxicities by that antibiotic, and stewardship pulse. So this is very important book. Then choose one patient every week and write one page analysis about it, that what was the syndrome, source, differential diagnosis, what was the investigations done, microbiology, then how antibiotic reasoning was done, what was the stewardship decision taken, and then finally what was the outcome. So these all things is very important, how what weekly should be done, what daily should be done. So if someone is going to train the person personally, because it is not online and it is given in chat gpt, then reading or case analysis and microbiology correlations, these are the main thing which should be done regularly. Then what can be done is approach to fever of unknown origin in tertiary care hospital, where you should write the definition, the major causes, the diagnostic approach, the common mistake, and the role of empirical, because now one has covered this fever of unknown origin and it is very important. So it should be written separately with all of these headings. So these are this all is very important for the fourth day, and something, it is just giving the tips, and everything can be read in detail. So if you find anything wrong here, as it is all being given by chat gpt, there may be mistakes also. So if you find any of them, you just write it in the comment box. So that is all for today. We'll read the next topic next day. Thank you.